The DCO2 is a marker of alveolar ventilation in high frequency ventilation. So in conventional ventilation, the carbon dioxide is determined by tidal volume times frequency, while in high frequency, an increase of DCO2 usually decreases the PCO2, and it is equal to frequency times the square of the tidal volume. So in high frequency, the tidal volume has higher impact than the frequency, and obviously if you keep the tidal volume constant, the frequency will make an impact, which is why it happens with the volume guarantee. In modern ventilators, we have tidal volume measurement as well as a display of the DCO2. DCO2 approximately a 40 to 60 ml square per kg is achieved, and we get a PA of CO2 in the permissive hypercapnia range if you have. But remember that the correlation varies between each baby, and once you know this correlation, it may help you to monitor the trend. A higher DCO2 is required with the higher size of the baby, where there is reduced spontaneous breathing frequency. So if you allow the baby to breathe in the background, you can do with the lower DCO2 and with the more severe lung disease. So you might need a lower rate and a higher tidal volume if the baby is bigger, and when you have paralyzed the baby as well, you need a lower frequency with a higher tidal volume. The DCO2 changes are achieved indirectly by changes in tidal volume by adjusting the amplitude as well as by changing the frequency. Higher tidal volumes are required for lower frequencies to achieve the same DCO2, and this increases the potential for volutrauma. What about the I time, amplitude and frequency? So the amplitude, the higher the amplitude, we need a higher tidal volume, we get a higher tidal volume. And in terms of frequency, the tidal volume will decrease with increasing frequency without volume guarantee. So the approach is different, and the tidal volume is increased by decreasing the frequency only if volume guarantee is not activated. But this occurs at a cost of increased transmission of the oscillatory pressure amplitude because there is reduced damping. So remember that if you reduce the frequency, you can cause more injury to the lungs. In terms of the IE ratio, the tidal volume increases when you change the IE ratio from 1:2 to 1:1. So if you want a lung protective strategy like an air leak or where there is already over distension, you would prefer a 1:2 or 1:3 strategy, while in the acute stages you may keep a 1:1 strategy for more effective ventilation. So there is a difference in the progression between high frequency with and without volume guarantee. So this just illustrates what the DCO2 is. So frequency times square of the tidal volume. So the more the frequency, the more the DCO2 would be if the tidal volume is similar. And if you lower the frequency because the tidal volume becomes more, you may compensate by that. In terms of high frequency without volume guarantee, when you reduce the frequency, you have an increase in tidal volume, and so we increase the DCO2 and reduce the PaCO2. But with volume guarantee, the tidal volume is constant, so when the frequency increases, because of this formula, your carbon dioxide will reduce and the DCO2 will increase. So you have to remember this difference when you are looking at volume guarantee. What about the IE ratio on high frequency? The inspiration to expiration impacts both the inspiratory and expiratory tidal volume, and the ratio of 1:2, where the inspiratory time is half of the expiratory time, or 1:1 where they are equal, is most commonly used. At any given frequency, if the IE ratio of 1:2, you will have a lower tidal volume and a relatively lower MAP than if an IE ratio of 1:1. So the ratio of 1:2 will enhance gas exchange, CO2 washout, while 1:1 may help oxygenation and keeping the lung recruitment. There are less clinical data on the use of appropriate settings, but in general, we suggest a ratio of 1:2 when there is gas trapping, like in air leak, meconium aspiration, and BPD. So where the time constant is longer, you want to keep 1:2.